it will be like a question answer based thing, and we'll be discussing the relevant options as well as we'll be discussing the tangential points also, important points. So the first question, all of the following are true about apoptosis except. So considerable apoptosis may occur in a tissue before it becomes apparent on histology. Apoptotic cells appear round mass of the intensely eosinophilic cytoplasm with dense nuclear chromatin fragments. Apoptosis of cells induce inflammatory reaction. Macrophages phagocytose the apoptotic cells and degrade them. Yes? What is the answer for this? True about apoptosis. All of the following are true except which one is false in apoptosis? Yes, the answers have started coming. Yes, very good. Very good. Exactly. Correct. So the options have come. Let's see the options one by one. Normally, if you see apoptosis in a tissue, if you see apoptosis in a microscopically in a tissue, considerable apoptosis would have already occurred and much of the tissue would have gone for the cells would have gone for apoptosis before it is visible to the microscopic morphologically. And usually apoptotic cells, what will happen? No, the cell size will be shrinking. So cell size will be shrinking. And another important keyword in apoptosis you have to know is the chromatin. The chromatin will be condensed. The chromatin will be condensed. So, and this thing will be the apoptotic cell will be intensely eosinophilic. The apoptotic cell will be intensely eosinophilic. That is, it will be appearing more of pinkish in nature. It is these apoptotic cells which will be appearing more pinkish in nature and will be shrunken. Remember, what is the apoptotic bodies which you can see in a hepatitis? In a viral hepatitis, what do you call that apoptotic bodies? In a liver, what will be the apoptotic bodies in case of viral hepatitis? Yes, it is Councilman bodies. So Councilman bodies also in a liver biopsy, if you see very darkly pinkish shrunken cell, you think of Councilman bodies. Okay, so Councilman bodies are nothing but apoptotic bodies, and these apoptotic bodies will be appearing more of eosinophilic in nature. And very important point, the macrophages phagocyte the apoptotic cells and degrade them. Normally, what will happen after apoptosis? The cells, the apoptotic bodies will be formed. This will be intact round bodies, and macrophages will recognize these apoptotic bodies and will try to phagocytosis. And the mechanism of phagocytosis which occurs in apoptosis is called as efferocytosis. And please remember, apoptosis, the cell membrane is intact. So there is no inflammatory reaction. But in necrosis, the cell membrane will be damaged, and this results in the inflammation in necrosis. Very important point. Necrosis inflammation will be seen, and apoptosis inflammation will not be seen. In this context, a quick review about the necroptosis. Necroptosis is nothing but necrosis plus apoptosis. So what will happen in necroptosis? There will be programmed cell death. There will be a programmed cell death without caspase activation. So there will be without caspase activation. In necroptosis, there will not be caspase activation. Another important MCQ you have to know is necroptosis, inflammation will be present. Inflammation will be present in necroptosis. Another thing you have to know is pyroptosis. So pyroptosis, what will happen? It is also a programmed cell death, but here in pyroptosis, there will be caspase activation will be there. Caspase will be activated in pyroptosis. So what you have to remember in pyroptosis, you have to remember the bacterial antigens. Yes, very good. The bacterial antigens will combine with either toll-like receptor, or they will be combining with node-like receptor. They will be combining with a node-like receptor. So when it combines with the toll-like receptor, it activates the caspase 11. It activates caspase 11, and in node-like receptor, it activates the caspase 1, and thereby stimulating the interleukin 1 and interleukin 18. And this results in the fever, pyroptosis, fever-like symptoms will be there in case of pyroptosis. Yes, the organelle involved in this pyroptosis we have to know is inflammasome. Very good. Inflammasome. The organelle involved in pyroptosis is inflammasome. Another recent update in your 10th edition of the Robbins is the ferroptosis. Ferroptosis. We all know that ferroptosis, Fe, that is apoptosis occurring in a cell when there is increased intracellular ion. Apoptosis occurring in a cell when there is an increased intracellular ion or reactive oxygen species. Reactive oxygen species. Please remember, in this ferroptosis can be inhibited by decreasing the intracellular ion levels or increasing the antioxidants. Ferroptosis, it occurs because of increased intracellular ion as well as increased reactive oxygen species. The ferroptosis can be reduced by decreasing the intracellular ion and increasing the antioxidants. So ferroptosis, another important point you have to remember, there will be membrane lipid peroxidation will be there. Membrane lipid peroxidation will be there in apoptosis. And also please remember, apoptosis, the stains for apoptosis are Fulgen stain, acridine orange, annexin 5. These are all the stains for apoptosis. Tunnel assay for apoptosis. And in agar gel electrophoresis, apoptotic cells will appear stepladder pattern. Whereas necrosis, there will be smearing or smudging pattern will be there. Okay. So now moving on to the next question. All of the following are true about autophagy except because autophagy, much more additional points have been given in the recent 10th edition of the Robbins. It is an update, recent update. So autophagy, there will be a high chance of asking in your upcoming exams. So let us see what is the things about autophagy. So all of the following are true about autophagy except autophagy can promote cancer growth and act as a defense against cancer. Alzheimer's disease is characterized by impaired autophagosome maturation. Macrophage-specific deletion of ATG5 protects against tuberculosis. Single nucleotide polymorphisms in the autophagy-related gene, that is ATG16L1, is seen in inflammatory bowel diseases. Yes, let's see who will answer for this thing. Yes. Already Harish has answered. Bharat is yes. Actually, people have been choosing between two options, A and C. Please remember, this is a very important topic, autophagy, and I want you to insist all to be learn this important point that autophagy, yes, autophagy can promote cancer growth as well as it acts as a defense against cancer. So whenever cancer has occurred, the cancer cells will be keep on proliferating rapidly. So when they rapidly proliferate, they need lot of energy. So for their cell division, they need lot of energy. For that energy, they cannibalize, that is, they engulf their own cell organelles, thereby they derive the energy needed for the cell division and also the intermediate products needed for the cell division. So by cannibalizing their own cell organelles, it actually it escapes the mechanism of deprivation, nutritional deprivation, thereby the cancer cell survives by autophagy. This is by how it promotes the cancer growth. Autophagy promotes the cancer growth. Autophagy is nothing but eating up one's own cellular organelle. The cell eats its own cellular organelles. Then how it can act as a defense against cancer. Say, for example, a cell has undergone a mutation. A cell has undergone a mutation and it is supposed to divide. The mutated cell cannot divide, should not divide. So what happened? Body makes a mechanism. So the cell digests its own cellular organelles. So thereby the cell division is stopped. Thereby the cell division is stopped and the mutated cell will not be allowed to progress or divide further. Thereby autophagy actually acts as a defense against cancer formation. Cancer cells will not be allowed to proliferate. So please remember, autophagy can promote cancer growth as well as can act as a defense against cancer. And Alzheimer's disease, autophagy plays a major role in neurodegenerative diseases. So what happens in Alzheimer's disease? So this point is right. Alzheimer's disease is characterized by impaired autophagosome maturation. Autophagosome. For remembering this, we have to know the different types of autophagy. That is microautophagy, macroautophagy, and you have chaperone mediated autophagy. So what happens in macroautophagy? The phagosome and the lysosome will fuse, like what it happens in the phagocytosis. The phagosome and lysosome fuses, so that results in an autophagosome formation. So if it involves the phagosome and lysosome fusion, then it is macroautophagy. And if it is just an invagination of the cellular membrane resulting in the phagocytosis of the cellular organelles, then it is microautophagy. And a chaperone are nothing but chaperones of the proteins which are essential for the protein folding, normal protein folding of in our cells. So what happens? The chaperone will mediate the autophagy. So that is the chaperone mediated autophagy. So what happens in neurodegenerative diseases like Alzheimer's? There will be impaired autophagosome maturation. Also, please remember, even in Huntington disease also, there is impaired autophagy. And this single nucleotide polymorphisms in the autophagy related gene, remember this gene ATG16L1 is actually seen in both ulcerative colitis as well as Crohn's disease. The single nucleotide polymorphism in this autophagy related gene is seen in ulcerative colitis and also in Crohn's disease. So what happens in autophagy? There is a gene called as, you have to remember, ATG5. Actually, autophagy plays a major role in killing of the infectious agents like tuberculosis, herpes simplex virus 1, and also Shigella. Note down these very important agents. Autophagy plays a major role in the body's killing of this tuberculosis, Shigella, and herpes simplex virus 1. So this gene, ATG5 gene, is responsible for this killing of the agents by autophagy. So what will happen when there is a deletion of this gene? Actually the patients will be susceptible to this infection, because these infections will not be eliminated and patients will be susceptible to the infections by tuberculosis, Shigella, and HSV1. So it is not protects against tuberculosis. Actually, they are susceptible to tuberculosis. So this is the option which we have to choose. Okay. Then identify the pattern of inheritance. So who will tell me the pattern of inheritance of this pedigree chart? Yes. They are saying, many are saying A, but why can't it be a other thing? Yes. Yes. So let us see this pattern of inheritance. So here what happens, because many of you would have thought that autosomal dominant, because every generation there is one person is affected by the disease. So you thought that, okay, in the first generation also one person is affected by the disease, second also affected, third also affected, fourth also affected. But see in this pedigree how the pattern of inheritance, how the disease is transmitted to the offspring. So if you see, this is the involved father. actually the male is getting affected here. The father is transmitting the disease only to the female. See here. This is actually a father, male affected with XY, male is affected, and he is giving the disease to all his daughters. So that means what? Father gives Y chromosome to the boys, to his sons, and gives X chromosome to the all the daughters. See, all these daughters, all these three daughters will receive the X chromosome only from the father. Okay, they receive the X chromosome from the father. Usually all these females are the XX, no? So one X they will be receiving from mother, and one X they will be receiving from father, and this X is affected in this father. So all these females are affected. See here. Even see here also the father is affected and he is transmitting only to the daughter, and males or sons are not affected. Sons are not affected. Similarly, if you see here, a affected female will transmit the disease both to the daughters as well as sons, because sons will get X chromosome only from the mother, and his daughters also will be getting the X chromosome from the mother. So female can transmit the disease to both the sons and daughters, and the fathers can transmit the disease only to the daughters. This pattern of inheritance. So there is a X-linked is there. So it is following in all the generations. It is occurring in all the generations. So this is a case of X-linked dominant inheritance. Dominant inheritance. Yes. Now, who will tell me this pattern of inheritance? What is this pattern of inheritance? This is the one most of you got confused with, this pattern of inheritance. Yes, very good. Very good, Dr. Bala. Yes. The YouTube also people can chat. Yes. Yes. See here, if you analyze this pattern of inheritance, both females as well as males, both are getting affected. But what happens every generation, that's one people or people are getting affected. So there is both males and females are getting affected, and there is no skipping of the generation. All the generation, one persons are getting affected. And also it is like a transmitted from one generation to another, like grandfather to father and father to son, like in a vertical pattern of inheritance. So these 3 points, please remember: vertical pattern of inheritance, and every generation there is no skipping of generation, both males and females are affected. This pattern of inheritance is autosomal dominant inheritance. Autosomal dominant inheritance. Now let's see this pattern of inheritance. What is this pattern of inheritance? What is this pattern of inheritance? Why? Yeah, actually, there are different kinds of answers. Let us see here how people are answering here. See here, here also, both males and females are affected. Both males and females are affected. But what is very important you have to know is, in the first generation, one person is affected, but in the second or in the third generation, there is nobody is getting affected in the family. So that means there is a skipping of the generation is there. This is a very important point. Skipping of generation. Skipping of generation is seen here in this type of pedigree. Skipping of generation. At the same time, what will happen? The person will be getting affected only if he or she marries another person from some other family having the same recessive gene. So it is a horizontal pattern of inheritance. What we saw in this autosomal dominant, it is a vertical pattern of inheritance from one generation to another. From one generation to another, the disease is passed. This is vertical pattern of inheritance. But if you see here, there is a skipping of generation. So the person would have been harboring the recessive gene. Only if he marries another person with the recessive gene, then he or she will manifest the disease. So this type of horizontal pattern of inheritance with the skipping of generation, that pattern of inheritance is autosomal recessive. Autosomal recessive. Very good. Many of you have answered this as autosomal recessive. Yes. Now let's see what is this pattern of inheritance. this pattern of inheritance. So what is the pattern here? Yes, this is the pattern which is so called, yes. Yes, this is the pattern, actually the so-called, see, the females, if they denote a symbol like an inside dot, it is a carrier. So see, females are carriers, and males are affected by the disease. Males are affected by the disease. So it is like a X-linked pattern, X-linked pattern. Why this is a X-linked pattern? Because actually the female, it is she gives the X chromosome to the son. The son receives X chromosome only from the mother. Father gives only Y chromosome to a son. Son receives only X chromosome from the mother, and the mother here is having a X-linked recessive gene which she transmits to her son. So the son is affected by the disease. The son is affected by the disease. So this pattern of inheritance is called as X-linked recessive. X-linked recessive. So females are carriers. Can anybody think of in which condition females will be getting affected? X-linked recessive disorders. All of us know the example, common examples, hemophilia, color blindness, and all those things. So in which condition in X-linked recessive disorder can occur in a female? Hemophilia can occur in a female. Yes. Turner syndrome, very good. Turner syndrome, when there is a 45X0. And also in case of Lyon's hypothesis, lionization. Yes, Lyon's hypothesis. What does Lyon's hypothesis says? There will be random inactivation of a X chromosome. See, this female is having one recessive gene and one dominant gene. She will be having one recessive gene and one dominant gene. So if there is an inactivation of a normal X chromosome, then that case, that is a Lyon's hypothesis, says one X chromosome should be inactivated. So if the normal X chromosome is inactivated, then in that case also female will be getting affected. And also in case of Turner syndrome. Very good, very good. Now, what is this pattern of inheritance? We have discussed all the other patterns, so it will be easy for you. And also it is one of the easiest pattern to identify. It is one of the easiest pedigree chart to identify. Yes, it is the easiest pedigree chart to identify. Yes, very good, very good. See here, both males and females are getting affected, but a affected male is not transmitting the disease to any of the offspring. The affected male is not transmitting the disease to any of the offspring, whereas the affected female is transmitting the disease to all her children. All her children. See here, the same pattern here also. Affected male, all the children are normal, but affected female, all the offsprings are affected. So this is called as mitochondrial pattern of inheritance. Very good. This is mitochondrial pattern of inheritance. All of us get our mitochondrial gene only from our mother. From our mother only we are getting our mitochondrial genes. So father is not giving the mitochondrial gene. So if mother is giving the mitochondrial gene, she gives mitochondrial gene to all the offspring. So if it is affected, then all the offsprings are getting affected by this mitochondrial disorders. Okay, so mitochondrial disorders usually you will be getting the central nervous system, muscles, and malas, those syndromes. Please remember the examples of mitochondrial pattern of inheritance. Okay. Now, a very important and a very easy question for you all. A 15-year-old boy complains of regular bone pain. Radiographic studies revealed several radiolucent defects. And on physical examination, there is hepatosplenomegaly. No external anomalies are present. A bone marrow aspirate is performed and a high magnification of the sample shows the findings depicted in the image. An inherited deficiency of which of the following enzymes is most likely to produce these findings? Yes. So this is actually a very important picture which all of you should remember. And here it is a boy and presenting with a bony lesion. And also the bone lesions will radiologically showing the radiolucent thing. And there is organomegaly is also there. So usually in case of this organomegaly with this bony pain, they will be doing a bone marrow aspirate. And this bone marrow aspirate, you are seeing this peculiar cells, which is one of the very repeated MCQ, very important image, which will be seen in getting all your exams. So these are all the macrophages. Okay, these are the macrophages with distended lysosomes. These are the macrophages with distended lysosomes you can get in a bone marrow aspirate, and these cells are called as Gaucher cells. Gaucher cells, and a typical appearance of this is a crumbled tissue paper appearance. Crumbled tissue paper appearance. Crumbled tissue paper appearance. So this Gaucher cells with a crumbled tissue paper appearance gives you a diagnosis of Gaucher's disease, and the enzyme deficient in Gaucher disease is glucocerebrosidase. Glucocerebrosidase. And here in this context, yes, very good, very good. In this context, you also have to remember what are pseudo Gaucher cells. What are pseudo Gaucher cells? What are pseudo Gaucher cells? Pseudo Gaucher cells, the other name for the pseudo Gaucher cells are sea blue histiocytes. In which condition you will be seeing pseudo Gaucher cell? That is conditions mimicking, see the cells will be mimicking like that of a Gaucher cells. Which condition? Yes, very good. Okay, it is seen in CML, thalassemia, Hodgkin's disease, very good. Hodgkin's disease, and also in multiple myeloma. In multiple myeloma. Please remember these conditions. Pseudo Gaucher cells, yes, very good. Pseudo Gaucher cells or sea blue histiocytes are seen in CML, thalassemia, Hodgkin's disease, and multiple myeloma. Okay. Now again say this. Another MCQ, a 9-month-old infant has had numerous viral and fungal infections since birth. On physical examination, congenital anomalies are noted. Laboratory studies show hypocalcemia. Fish analysis of the infant's cell is performed, and a metaphase spread is shown in the image. And with probes to two different regions on chromosome 22, which of the following cytogenetic abnormalities is most likely to be present? Yes, I'm getting the answers correct. Yes. So what is the technique? This technique also actually in the previous exams also, the image of this technique has been put, and they were asking about what technique. So here they are questioning the answer itself they are giving. Yes, this fish technique, fluorescent in situ hybridization technique, a very important genetic diagnosis, a diagnosis of genetic disorders. You have to know this fish technique. So what is this? Actually in the fluorescent in situ hybridization, they will be using a DNA probe which is fluorescently tagged. So what will happen? So they will be using a control probe, and they will be also checking it whether the required probe is, whether the required signal is expressed or not. So in this case, the control probe is localizing to the 22nd chromosome, and another probe to the Q11.2 that is present here. But here in this chromosome, if you see, there is actually only one signal is there, and there is a deletion of the other gene. Okay, there is deletion. So here you can see two signals, and here there is only one signal. That means what? Actually in the chromosome 12, the another probe, that is the 11.2, Q11.2, that is actually being deleted. So there is a deletion of this 22Q11.2, and it is in a child and is prone for this viral and fungal infections, and also with a hypocalcemia. So this makes a diagnosis of DiGeorge syndrome. So it is a 22Q11.2 deletion. That part is being deleted. So what are the other important MCQs which can be asked? This DiGeorge syndrome, or the other spectrum is velocardial facial syndrome. Velocardial facial syndrome. So it is actually a continuous of the spectrum. It is actually a continuous of the spectrum. In DiGeorge syndrome, actually yes, very good, catch 22. In DiGeorge syndrome, there will be actually the more of immune abnormalities will be there. If the facial abnormalities, if there is a coarse facial features and there will be a cardiac abnormalities, then you give the spectrum velocardial facial syndrome. And also please remember the gene TBX1 gene. Okay, TBX1 gene you have to remember when discussing about this DiGeorge syndrome and velocordial facial syndrome. Okay, then coming to the next question, which of the following procedures used as a routine technique for karyotyping using light microscopy? So routine technique is this question actually the related to this banding technique was asked in your last exam. So I thought that we will discuss this question because there will be a tangential other things are also there. So everybody knows G banding, that is the GIMSA banding, is the normally commonly used routine technique for karyotyping. But let us not stop with this point. Let us discuss all the other types of banding also. Please remember the 4 types of banding which are commonly performed in case of chromosome. This banding technique actually will be staining a chromosome. What is this banding? So banding, normally when you will be reading about the chromosomes, you will be seeing that there will be a centromere and there will be having a one short arm. The short arm you will be denoting it as P, and the long arm you will be denoting it as Q. P means petit. Petit means small. Okay, in French, petit means small. So P means it is short arm and Q means it is a long arm. So you will be further staining the chromosomes and you will be staining based upon the patterns, band, region, subregion, band, subband, like that you will be further localizing. You may be hearing, so like some genes, 11.2.2, that means 11th chromosome, this particular region, particular band, particular subband, that you want to localize a particular gene to a particular location. So for that, you have to stain the chromosome. For that staining, you use the technique banding. So Q banding is nothing but you use a stain called as quinacridine stain, and it will be staining the AT rich regions of the DNA, adenine and thymine rich DNA regions of the DNA. So how you will be studying this stain? You, after staining with quinacridine, you will be using a UV light. Okay, you will be using a UV light, that is the fluorescent banding pattern for each chromosome. Okay, and the G banding is the staining is the GIMSA staining, so only it is called as G banding. Here also you will be staining the AT rich parts of the DNA, AT rich parts of the DNA, and it is the most frequent method. And in this GIMSA staining, you have to pre-treat the cells with a trypsin, enzyme trypsin. And alternate stain which can be used here is a right stain. And this is very important, this point. These 2 points are very important. Trypsin and alternate stain is right. Let us see the other banding, that is R banding. R actually stands for the reverse. R stands for the reverse. See here, in all this Q banding and G banding, you have stained the AT rich DNA. Okay, AT rich parts of the DNA. But in reverse, you will be staining the GC rich part of the DNA. GC rich part of the DNA. So what will be happening? So exactly the opposite will be happening. So exactly you will be seeing a reversing banding pattern. So whatever you observed in Q and G banding, here in R banding, you will be observing in a reverse pattern. So this technique is useful for identifying chromosome. And please remember, when you want to stain the telomeres, all of you know that these telomeres are at the tip of the chromosomes. No, they shorten after every cell division. No, so if you want to particularly stain the telomeres, the technique of choice is R banding. That is the reverse banding. Here you have to use heat denaturation. And another thing you have to know is C banding. C banding. C, remember C for centromere. C for centromere. So you want to study the centromere region purposefully. Okay. And also if you want to study the distal part of the Y chromosome. So all these things you have to use C banding. You have to use C banding, which also stains the AT rich parts of the DNA. And here you have to pre-treatment with the alkali, and the very important for studying the centromere, use C banding. Okay, and this is one of the banding technique actually which is variable from person to person, highly variable. Okay, this other banding technique like Q, G and all, it's not variable from that much variable, but this C banding is highly variable from person to person, very important. Okay. And previous years, actually, they were asking about that types of the chromosome. the chromosomes based upon the position of the centromere. They are divided into metacentric, submetacentric, and acrocentric. And the telocentric chromosomes are not seen in humans. Okay, just go through the list of the chromosomes which is metacentric and which is submetacentric. 1, 2, 3 are metacentric, 4, 5 are submetacentric. And please remember, X chromosome. X chromosome is submetacentric, and Y chromosome, which is actually the very short chromosome, actually this is acrocentric. Please remember, X chromosome submetacentric, and Y chromosome it is acrocentric. Other acrocentric chromosomes are 13, 14, and 15. So they are grouped into group A to G. Actually, though you before the exams, just go through this tabular column, and at least you have to definitely remember what is the chromosome of X and Y, under which group it will be belonging to. Submetacentric, 16, 17, and 18, meta or submeta. This 19 and 20 can be having a meta or submeta pattern of position of the centromere. Okay. Then the next question, which of the following is not true about cancer cachexia? Cancer cachexia, that is a terminal illness of the cancer. Which of the following is not true? Equal loss of both fat and lean mass, muscle, elevated basal metabolic rate, no evidence of systemic inflammation, TNF alpha cachectin plays an important role. Cachectin plays an important role. Yes, what is the answer for this question? Yes. What will happen in cancer cachexia? There will be equal loss of both fat and lean muscle mass. Both will be lost. And in cancer cachexia also, please note down that TNF, that is a tumor necrosis factor, is a major contributor. So as there is more loss of body fat and lean body mass, so what will happen? The basal metabolic rate will be very much increased in patients with the cancer cachexia. So the BMR will be very high in case of cancer cachexia. And what will happen during this destruction? The acute phase reactants will be elevated. There will be increased acute phase reactants, and this will trigger the systemic inflammation. This will trigger the systemic inflammation. And always, actually, there is a loss of body mass. So there will be a negative nitrogen balance will be there. Negative nitrogen balance will be there. So let us come to the option here. So there will be equal loss of body fat and lean muscle. Elevated basal metabolic rate will be there, and TNF plays a major role, but there will be increased elevation of, means increased acute phase reactants will be there, and there will be systemic inflammation. So this option is the wrong option. So in this context, a quick review about the tumor lysis syndrome. So what is tumor lysis syndrome? When the tumor with a high bulk of these tumor cells, rapidly proliferating tumors, the tumor cells like Burkitt's lymphoma, ALL, and in certain chronic leukemias, the tumor load, that is the tumor cell mass, is highly proliferating. So what happened when there is a high turnover of the cells, or when they initiate the chemotherapy, when large number of cells die at once, tumor lysis syndrome. So when the tumor cells are killed immediately or at a time, single point of time, what happens? All the tumor cells will be lysed, and immediately there will be release of more uric acid from the nuclear material. So there will be hyperuricemia. These patients will be having hyperkalemia, which can be a life-threatening, hyperphosphatemia, hypocalcemia, acidosis, and renal failure. So please remember, one of the commonest conditions in which tumor lysis syndrome can occur is Burkitt's lymphoma, ALL, and chronic leukemia. Hyperphosphatemia, hypocalcemia, acidosis, hyperkalemia. Please remember this thing. One of the high-yield topic in your INI-CET exam, which of the following vacutainer contains heparin as an anticoagulant? Which of the contains a heparin as an anticoagulant? Yes. Yes, very good, very good. So let us have a quick review about these different types of vacutiners. So the commonest vacutiners, let's us go through. That is the blue topped one. That is the light blue topped one vacutainer, which contains actually the anticoagulant additive contains 3.2% sodium citrate, 3.2% sodium citrate. And it is used when you want to estimate the PT, APTT, that is for the coagulation studies, D-dimer. When you want to estimate this coagulation related parameters, use blue topped one with sodium citrate, 3.2 sodium citrate. And the red topped one, which will not contain any anticoagulant. So instead, it will contain a clot activator. So when clot is getting activated, you will be getting serum, only serum. So where you will use serological test, biochemistry and microbiological test, microbiology department. So there you will be mainly using this red topped one without any anticoagulant. Okay. And also when you want to do therapeutic drug monitoring. And the golden yellow color one, which will contain actually the glass clot activator and a serum separator tube. This also actually the serum will be collected. It is almost similar to like the red top one. In addition, for drug monitoring, thyroid profile and vitamin B12 and folate, you will use a yellow top, that is a golden yellow color, one topped vacutainer. And the green topped one, that is, please remember, heparin, sodium, it can be a sodium heparin or lithium heparin. Whenever you want to do a chromosome study, when you want to do a chromosome analysis, genetic study, use this heparin, that is the green topped one. And also HLA typing for doing transplantation. So clinical scenario can be framed based upon, they can give you a transplant scenario where in which vacutainer the blood sample should be collected. Like that, the question can be framed. Okay. And for ABG analysis also, you have to collect it in a green topped one. And the most commonly used one, that is the purple colored or the lavender topped vacutainer, which is contains a sodium, this potassium EDTA, ethylene diamine tetraacetic acid, as an anticoagulant. So it is one of the commonly used in a clinical pathology laboratory, where the common blood tests like CBC, ESR, Wintrobe, HbA1c, do all biochemical tests, actually we will think of this red topped one. If they specifically ask HbA1c, please choose this purple color one. And also this routine hematology, RBC count, WBC count, all these counts, no, CBC. And also for molecular testing, we use a purple or lavender color one. And the very important, another important one is the gray topped one. That is a gray topped one vacutainer, which contains a potassium oxalate as an anticoagulant, and it will contain a sodium fluoride. Why the sodium fluoride additive is added? Sodium fluoride additive is added because, yes, very good, Arun. It inhibits the enzyme enolase. Enolase enzyme is inhibited, so glycolysis is prevented. So exactly you can measure the exact glucose levels. Very good. So for exact glucose estimation, which vacutainer you will be collecting the sample, it will be in a gray topped vacutainer, Now let us few also actually last exams, if you see, they also touch the topic of the blood bank. Okay, transfusion pathology also some questions have been asked. So let's see this question. Cryoprecipitate contains all of the following except. Cryoprecipitate contains all of the following except, yes. Yes. For this, we have to know the constants of this component therapy in the blood bank. This packed RBCs, usually the volume will be 240 ml, and it can contain some amount of WBC also. And please remember, a single bag of RBC, packed RBC, will increase the hematocrit by 3%, and the hemoglobin 1 gram per deciliter, 1 unit of packed RBC will increase the hemoglobin by 1 gram per deciliter. And platelets bag usually contain a 50 ml of platelet, 50 ml. So the bag is actually a 50 ml one, and each unit will increase the platelet count by 5,000 to 10,000. So the clinical scenario based questions can be framed, and they can ask you how many platelet bags you want to transfuse. Like that, the question can be framed. And fresh frozen plasma, the volume is 250 ml. And please remember, fibrinogen, antithrombin 3, factors 5 and 8. Fresh frozen plasma is rich in factor 5 and factor 8. And each unit will be increasing by fibrinogen by 10 milligram per deciliter. And this is our question. That is a cryoprecipitate contains 40 ml, contains fibrinogen, factor 8, 13, 1 milligram factor. So fibrinogen, factor 8, 13 and 1 milligram factor are seen in cryo, and usually this factor 9 will not be there in a cryoprecipitate. This is very important. Okay. And the storage temperature is also important. Whole blood and packed cells are stored at +2 to +6 degrees centigrade with a shelf life for 42 days. And there has to be transfusion has to be started within 30 minutes of removal from the refrigerator. And it has to be completed within 4 hours, RBC and this whole blood. Whereas platelets, the shelf life is just 5 days. The shelf life is, platelets is shelf life is 5 days. And it should be reinfused as soon as possible. When you remove from the blood bank, immediately it has to be the transfusion has to be started and it has to be completed within 20 minutes. The same applies to fresh frozen plasma and cryo. One important thing, fresh frozen plasma and cryo has to be thawed before it has been transfused because they are in a cryo precipitate, no? They are frozen state, no? So they should be thawed before transfusion. So within 20 minutes. Okay. So let us see the another important question. A 28-year-old woman presents with increasing fatigue for the past 6 months. On physical examination, she has mild splenomegaly. Laboratory studies show a hemoglobin concentration of 9.7 gram per deciliter and a hematocrit of 31.2%. And the peripheral smear findings are shown in the image. Direct and indirect Coombs test results are positive at 37 degree and not at 4 degree. So which of the following is the most likely in this patient? Yes, this is something like a tricky question. So she's a female, 28-year-old female having increasing fatigue. That means she is having anemia. Increasing fatigue tells you that she is having a anemia. Yes, it is not, yes. On physical examination, mild splenomegaly is the and hemoglobin is reduced. So another important clue they are telling you is the in the peripheral smear findings. So in the peripheral smear findings, what you are seeing, you can see some enlarged cells and also you are seeing some small cells and these cells are spherically appearing. They appear very spherical and no, they are not LE bodies. They are actually, if you see, there is no central pallor. See here, this cell has a central pallor. This is a normal RBC with a central pallor. But these are all the cells without any central pallor. So these cells are called as spherocyte. So these cells with the spherocytes will not have central pallor. And also please remember, apart from these RBCs, you are seeing these kind of cells. So what are these kind of cells? These are nothing but the nucleated RBCs. These are nothing but the nucleated RBCs. When you will get nucleated RBCs in a peripheral smear, it tells you that there is an excessive hemolysis which is occurring in the patient. So to compensate for the hemolysis, the more of premature RBCs are released in the circulation. So spherocytes and nucleated RBCs. And also another important clue you are getting is very important clue for the diagnosis. Direct and indirect Coombs test results are positive. Coombs test are positive. That means what? There is some antibody is present. Then there is some antibody is present and that is destructing the RBCs. So these antibodies are positive at 37 degrees centigrade, but they are not at 4 degrees centigrade. That means they are warm antibodies. Warm antibodies are positive at 37 degrees centigrade. And with the clinical scenario in a female with hemolytic anemia, the diagnosis here is a systemic lupus erythematosus, which actually causes is one of the cause for warm autoimmune hemolytic anemia. Another important point here we have to remember, a mere presence of spirocytes, we should not make a diagnosis of hereditary spirocytosis because spirocytes can be seen not only in hereditary spirocytosis, they can be also seen in warm autoimmune hemolytic anemia, burns patient, sepsis patient, and clostridial infections. So in all these conditions, you will be getting this spirocytes in the peripheral smear. Okay. So now let's see this question. A 45-year-old female with a 26-year history of rheumatoid arthritis. See, there is a 26-year history of rheumatoid arthritis. Presence with easy fatigability and shortness of the breath. She is still menstruating. Laboratory studies reveal a white blood cell count of 3,700 and a hemoglobin of 10.2 and hematocrit of 32%. And the MCV is 71 femtoliter. And which of the following tests would be the most will be most help to confirm the diagnosis. So she is a female of 45 years, and they have said that there is a long history of rheumatoid arthritis. So there is a 26-year history of rheumatoid arthritis, which is a chronic disease. And also she is complaining of easy fatigability and shortness of breath, that is the anemia is there. But one more important clue they are giving is she is still menstruating. That means what? So menstrual related abnormalities can also be there. She can be also menorrhagia, having menorrhagia. That can also be leading to iron deficiency anemia. So here they have given you the hemoglobin 10.2 and the hematocrit is less and MCV is 71. So this is a microcytic hypochromic picture. So microcytic hypochromic picture, the two differentials are anemia of chronic disease and your iron deficiency anemia. So very important point to differentiate this iron deficiency anemia and anemia of chronic disease will be actually two important parameters. Actually here they are not asking you what is the diagnosis. They are leaving us to like what measurement of which parameter will make a diagnosis. So for this, we have to know the terminologies and the differential diagnosis of a microcytic hypochromic anemia, that is iron deficiency anemia, anemia of chronic disease, thalassemia minor, and sideroblastic anemia. So one important point to differentiate anemia of chronic disease and iron deficiency anemia is the total iron binding capacity will be raised in iron deficiency anemia and it will be low in case of anemia of chronic disease. Similarly, the opposite thing will happen in ferritin, the serum ferritin, which is a storage form of the iron. Serum ferritin, which is a storage form of the iron, will be reduced in iron deficiency anemia and raised in anemia of chronic disease. These two parameters will help us to differentiate between iron deficiency anemia and anemia of chronic disease. Whereas the serum iron, erythrocyte protoporphyrin, and blood smear all will be the similar parameters. Serum iron will be reduced both in IDA and anemia of chronic disease. And also this free erythrocyte protoporphyrin levels will be increased in both IDA and anemia of chronic disease. And another important parameter here we have to remember is in sideroblastic anemia, most of the parameters will be raised. Okay, serum iron, transferrin saturation, serum ferritin, marrow iron stores, everything will be raised in sideroblastic anemia except free protoporphyrin levels, which are decreased in sideroblastic anemia. Okay, and HB electrophoresis will make a diagnosis, will help us to make a diagnosis in thalassemia minor. Another very important clue. Here in thalassemia minor, this MCV, MCH, and MCHC are very low. So another important parameter which related to last exam, one question was asked, that is the Menzer index. What is this Menzer index? This index helps us to differentiate between a iron deficiency anemia and a thalassemia minor. So what is the formula for Menzer index? It is MCV, that is the mean corpuscular volume divided by RBC count. More than 13, it is iron deficiency anemia, and less than 13, it is thalassemia trait. This is the formula for Menzer index. So in the question, if the examiner gives you the values of MCV and RBC count, that means you can definitely calculate the Menzer index and you can make a diagnosis whether it is iron deficiency anemia or thalassemia. So iron deficiency anemia, both MCV and RBC will be low. And in thalassemia, the RBC count will be normal and MCV will be low. Okay, so this, remember this Menzer index. Okay, then moving on to next question. A 51-year-old man has scaly erythematous lesion on skin over his face and trunk and has become scaly red with intense itching and a 5 kg weight loss over the past 3 months. On physical examination, there is a non-tender lymphadenopathy is present. His peripheral blood examination showed the cells as seen in the image. Which of the combination of the phenotypic markers is most likely to be expressed by these cells? Yes, the patient is mainly, it is an elderly patient with a scaly erythematous lesion on the skin. So scales all over the thing. And they are associated with intense itching with weight loss. So lymphadenopathy is also there. Peripheral smear, what is these peculiar cells? What is the morphology of these cells? See, these are all the atypical cells, which are very characteristic cells, which will be having a convolutions like this thing. Yes, these are nothing but, these are all the Sézary cells. Sézary cells. How will you identify a Sézary cell? The nucleus is cerebriform appearance. The nuclei is Cerebriform appearance in case of a Sézary cell. Cerebriform appearance in a Sézary cell. Okay, let me ask you one question. Cerebriform appearance in a gastric mucosa. Which condition you will be getting? Cerebriform appearance in a gastric mucosa. Anybody? Cerebriform appearance. Yes, menetrious disease. Very good. Cerebriform appearance in gastric mucosa, you will be getting in menetrious disease. Cerebriform or nuclei, you will be getting in Sézary cells. And the diagnosis of this condition is mycosis fungoides because of the presence of Sézary cells. And mycosis fungoides is nothing but it is a T cell lymphoma. Okay, it is a T cell lymphoma. So this T cell cutaneous lymphoma will be positive for CD3 and CD4. This is the answer. Okay. And what is this finding? So in a case of mycosis fungoides, in the epidermis, if you get a collection of this atypical lymphocytes, what is this finding called as? Yes, if you get a collection of this lymphocytes in the epidermis, you call this as a Pottier's microabscess. Pottier's microabscess. Okay, in which condition you will be getting micro-Munro abscess? Micro-Munro abscess and pustules of Kagoj are seen in which condition? Yes, that is in psoriasis. Please remember the tangential point. Another important point here you have to remember, here in this mycosis fungoides, the lymphocytes will move towards the epidermis. They are attracted towards the epidermis. And so in the squamous epithelium, you can see a lot of epidermis in the lymphocytes. And this mechanism is called as epidermotrophism. Very good. Epidermotrophism. Very good. Okay. Reed-Sternberg-like cells are seen in all of the following conditions except Reed-Sternberg-like cells are seen in all of the following. All of us know the classical morphology of Reed-Sternberg cell, but Reed-Sternberg-like cells apart from Hodgkin's lymphoma, there can be, all of us know that it is seen in Hodgkin's lymphoma. Which other condition it will be seen? Whether it is in adult T-cell lymphoma or extranodal lymphoma, diffuse large B-cell lymphoma, infectious mononucleosis. And for 3 of these conditions, RS cells-like cells are seen except 1. Yes, please remember the mnemonic DIA, that is diffuse large B-cell lymphoma, infectious mononucleosis, and adult T-cell lymphoma. In all these 3 conditions, you will get Reed-Sternberg-like cell, and the option here is in extranodal NK cell lymphoma, you will not see RS-like cell. Okay, so RS cells-like cells, also please remember other important MCQ, that is the lacunar RS cell, where you will be seeing lacunar RS cell. Lacunar RS cells, which type of Hodgkin's lymphoma you will be seeing? Here you will be seeing in nodular sclerosis. Very good. Nodular sclerosis. In which condition you will be seeing your popcorn cells? Popcorn RS cells. Popcorn RS cells are seen in? Popcorn cells are seen in? Yes. Lymphocyte, nodular lymphocyte predominant. Nodular lymphocyte predominant. You will be seeing popcorn kind of RS cells. And this is the classical RS cells with these are all the bilobed nucleus. So this is the nucleus. Okay, this is a large cell with a bilobed nucleus appearing as a mirror image of each other with a prominent eosinophilic nucleoli resembling like that of the owls. So in which viral inclusion you will be seeing owl's eye-like appearance? Which viral inclusion? Yes, CMV. Owl's eye-like inclusion, CMV. Yes. So if you get in a peripheral smear, this kind of, yes, very good, CD15 and 30 positive. In which kind of, in which condition you will be getting this kind of atypical cells? Yes, these are called as flower cells. These are called as flower cells, also called as clover leaf cells. Clover leaf cells. These are seen in adult T-cell leukemia bar lymphoma. Adult T-cell bar leukemia bar lymphoma. Very good. So if you see such things in your biopsy, in a histopathological image, what are these kind of cells? Yes, can you identify these kind of cells under the condition? This how these cells are looking like? Yes, these are called as the embryo cells. See, this is like looking like an embryo. And this is a donut cell. Embryo cell, donut cell, reniform cell, horseshoe-shaped cell. Okay, horseshoe-shaped cell. Which condition? It is not aplastic, it is anaplastic large cell lymphoma. Okay, anaplastic large cell lymphoma. Anaplastic large cell lymphoma. You will be seeing this embryo cells, donut cells, anaplastic large cell lymphoma. Yes, I agree. Okay, it is anaplastic large cell lymphoma, donut cells, embryo cells, reniform cells, and your fetal cells, hallmark cells. Okay. A 67-year-old woman presented with polyuria and bone pains. Her blood test revealed a high calcium and a serum electrophoresis was sent. Her paraproteins was 25 gram per liter and a bone marrow biopsy revealed 12% clonal plasma cells. The most likely diagnosis, yes, this is the plasma cell decreases is one of the very important topic, and recent the diagnostic criteria of multiple myeloma has been revised. So definitely there will be a high chance of asking. So let us revise what is the SLIM criteria and the CRAB criteria for diagnosis of this multiple myeloma. Please remember, as I already insisted during the class, SLIM and the CRAB actually they are nothing but the myeloma defining event. These criteria tells us that there is an end organ damage. The patient has gone for an end organ damage. So what is this SLIM criteria? Yes, for bone marrow should have 60% plasma cytosis. 60% of the bone marrow should be actually occupied by these plasma cells. And the light chains involved to uninvolved ratio is more than 100, and MRI should show more than one focal lesion. So this is the SLIM criteria. What is CRAB? CRAB is calcium hypercalcemia. Calcium levels are elevated, renal failure, anemia, and bone disease more than one lytic lesion on X-ray or CT or PET-CT more than 5 mm. Any one of this, even if any one of this SLIM criteria or any one of the CRAB criteria, if it is fulfilled, then we have to make a diagnosis. This is a myeloma defining event that gives a diagnosis of multiple myeloma. Apart from this, there should be a 10%, more than 10% clonal plasma cytosis. So in multiple myeloma, there is a clonality, monoclonal proliferation. So biopsy proven plasma cytosis should be there. So in this condition, actually the patient is having bony pains and polyuria, but they have already said that high calcium, so that the CRAB criteria, this is fulfilled, and the serum electrophoresis is also showing this paraprotein. So this is a case of multiple myeloma. Multiple myeloma. So please remember, in multiple myeloma, you will be seeing a gamma globulin spike, and there is a M band. Okay, in the electrophoresis, you will be seeing a M band or the M protein. Very good. Church spike pattern. And also please remember Benz-Jones protein. Okay, light chains. What is the specificity? What is the special feature of this Benz-Jones protein? Actually, on heating, it clots at, it forms a coagulum at 55 degrees centigrade. On further heating, actually, the coagulum redissolves at 95 degrees centigrade. Multiple, this Benz-Jones protein. So what is this finding? When you see this RBCs stacked as a coins one after the other, this finding is called as Rayleigh formation. Very good. This is Rayleigh formation. Rayleigh formation. So this is how you identify a plasma cell. Plasma cells will have a eccentrically placed nucleus. That is, the nucleus is placed one over the one edge of the cell, and you will be seeing a perinuclear halo. Okay, around the nucleus you will be seeing a more amount of empty space. Okay, empty space. Perinuclear halo. And what are these cells? That is the excess immunoglobulin secreted by these plasma cells stored in the granules in the cytoplasm, like a bubbly thing. Yes, these are called as Mott cells. These are called as Mott cells or grape cells. Grape cells. Yes, very good. Mott cells or grape cells. Very good, Dr. Jagadish. And what are these bodies? In the cytoplasm, what are these bodies? Yes, eosinophilic bodies, that is the immunoglobulins which are present in the cytoplasm. Immunoglobulins, these are all the Russell bodies. These are all the Russell bodies. So Russell bodies are in the cytoplasm. So what are the bodies which you can see in the nucleus? Can you see this in the plasma cell with the nucleus? So yes, nucleus, it is Dutch. So what mnemonic I used to tell in the class? DNA, that is the nucleus Dutcher bodies. DNA, nucleus Dutcher bodies, and cytoplasm, it is Russell bodies. It's very good, Dr. And what are these cells? Yes, cartwheel chromatin. Very good, Dr. Nivedita. It is a cartwheel chromatin. Clock-phase chromatin plasma cells will have. What is this type of cell? What is this cell? Again in plasma cell. Yes, it is a flame cell. So all these things will be characteristically seen in multiple myeloma. Yes, a 38-year-old man presented with a recent history of hepatitis B infection, presented with a reddish lesion over bilateral legs. Also complaints of vague diffuse abdominal pain with melena, but no masses were palpable. Laboratory studies showed an increased urea nitrogen and serum creatinine level. Urine analysis showed 3 plus proteinuria, biopsy of skin lesion shown in the figure. So there is a history of hepatitis B infection in a patient, and the patient is also having reddish lesions over the bilateral legs. Patient is having abdominal vessels involvement, so GI vessels involvement, that is giving rise to abdominal pain and melena, and his renal involvement is also there. Urea nitrogen and serum creatinine levels are elevated. Proteinuria is also there. And the biopsy finding, what you are seeing is, you are seeing a fibrinoid necrosis. Can you see this pinkish material deposited, fibrillar, bright pinkish material deposited in the blood vessel wall? This is the fibrinoid necrosis. But what is the characteristic finding here? It has to be noted in this biopsy is the one part of the vessel. See this one part of the vessel, it is uninvolved. Yes, yes, very good, Arun. One part of the vessel, it is normal. This is normal vessel wall is seen. But this part of the vessel, it is showing a disease. That is, all stages of the lesion are present in a single blood vessel. That is a normal blood vessel. Part of normal blood vessel is also the one part is affected. So all stages of the lesion are seen in a single blood vessel with hepatitis B infection, renal artery involvement, renal vessel involvement, and also abdominal vessel involvement. This makes a diagnosis of polyarteritis nodosa. Please also remember polyarteritis nodosa, pulmonary vessels are spared. Okay, ANCA, polyarteritis nodosa, ANCA will be negative. Negative. Please remember these important points. And microscopic polyangiitis, pulmonary capillarities can be seen. P ANCA will be positive, and all this means all the lesions will be of the same age in case of microscopic polyangiitis. By this only you will differentiate microscopic polyangiitis from polyarteritis nodosa. Okay. Yes. Again, a very important topic. A 55-year-old man succumbed to his illness of low output heart failure that was unresponsive to the medical treatment. The affected heart at autopsy weighed 900 grams. There was no definite evidence of coronary artery atherosclerosis. Histologically, the affected myocardium demonstrate the findings as shown in the figure. So, yes. Yes, what is the thing? So here, the man is actually having a low output heart failure, and the heart is actually weighing 900 grams. And very important one here you have to know here is, see this, the myocardial fibers are hypertrophied, agreed. But what is this actually, this finding of the nucleus? The nucleus, typical appearance of the nucleus is called as the ninja star appearance, So this is that ninja star appearance, and with this forms. And what you people have mentioned, many people have mentioned it as yes, ninja star. And what diagnosis you want to make? Yes, this is actually a case of ninja star appearance, and with this ninja star appearance and the myocardial fibers hypertrophied and the heart is weighing 900 grams. Please remember it is dilated cardiomyopathy. Those who are marked as a hypertrophic, please correct it. This is dilated cardiomyopathy. So dilated cardiomyopathy only you will be getting ninja star appearance. Okay, dilated cardiomyopathy. And also please remember what is the protein defected in dilated cardiomyopathy? Titin. And hypertrophic cardiomyopathy, you will be seeing haphazard arrangement of the muscle fibers. What you will told is myocyte disarray. So in hypertrophic cardiomyopathy, there will be myocyte disarray. Remember? Yes, helter-skelter deformity, which I was telling you in the class. Helter-skelter deformity. Yes, very good. In hypertrophic cardiomyopathy, that is hypertrophic obstructive cardiomyopathy, that one of the causes of death in young athletes, football players in the ground fell down and died. So that is hypertrophic obstructive cardiomyopathy. The interventricular septum as well as the left ventricle both will be hypertrophied and compressing the ventricular chamber into a banana-shaped cavity. That is helter-skelter deformity, myocyte disarray. This is actually ninja star appearance. In hypertrophic cardiomyopathy, what is the thing defective? It is beta myosin chain. Beta myosin heavy chain will be defective. And also please remember, dilated cardiomyopathy, you will be getting systolic dysfunction, whereas hypertrophic cardiomyopathy and restrictive cardiomyopathy, you will be actually getting a diastolic dysfunction. You will be getting a diastolic dysfunction. Is now coming back to this question. A 55-year-old male presented with a 6-month history of weight gain and depression. Physical examination showed moon phases and hypertension. CT scan of the thorax revealed a pulmonary mass. A transbronchial lung biopsy was done and a histopathological image is shown below. What is the most likely diagnosis in this patient? Yes, if you carefully see, the patient actually here, they will be presenting as a weight gain and depression. So weight gain and depression is the moon phases and hypertension. All these points to a diagnosis of actually a Cushing syndrome. Also, the CT scan of the thorax revealed a pulmonary mass. So what is in this biopsy finding you are seeing? You are seeing a cells which are having this somewhat granular cytoplasm. That is the granular nucleus, that is the salt and pepper chromatin. With a salt and pepper chromatin, and this is also mimicking like that. The cells are also mimicking like that of a oats shape, and so these are also called as oat cells. And these cells are highly rapidly proliferating. So the tumor cells, the nucleus of the tumor cells will be smudged around the blood vessel. Around the blood vessel, the nuclear material will be smudged around the blood vessel. And this phenomenon is called as a Azzopardi effect. So with this Azzopardi effect and the commonest Cushing syndrome as a paraneoplastic syndrome. So this Cushing syndrome is nothing but it is actually a paraneoplastic syndrome which occurs in this small cell carcinoma. So the diagnosis here is small cell carcinoma. Please remember, squamous cell carcinoma, the paraneoplastic syndrome, usually it will be seen as the hypercalcemia. Okay, hypercalcemia. Very good, Arun. It is hypercalcemia. And which is the lung cancer with a lot of paraneoplastic syndrome? It is a small cell carcinoma, which will be lung cancer with a lot of paraneoplastic syndrome. And also highly aggressive tumor lung cancer, small cell carcinoma. Okay, strongly associated with the smoking, small cell carcinoma. And which lung cancer is a hilar in location? Please remember, squamous cell carcinoma is hilar in location. So, carcinoma, lung cancer with a cavity formation, squamous cell carcinoma. Okay, squamous cell carcinoma also has a hypercalcemia as a paraneoplastic syndrome. Lung cancer, commonest lung cancer in females, commonest lung cancer in non-smokers, lung cancer which is peripheral in location. All these questions, the answer is adenocarcinoma. Very good. Okay, adenocarcinoma. Please remember what are the markers positive in adenocarcinoma? TTF1 and NAPSIN-A. Very good. Okay, TTF1 and NAPSIN-A. The commonest lung cancer also, it is actually the adenocarcinoma. So these are all the very high yield topic. Okay, please remember this thing. Another question, a 59-year-old male presented with a fever, dyspnea, and he had never had his regular health checkup due to his busy schedule. On evaluation, his chest radiograph showed multiple coin shadows. Laboratory investigations revealed a packed cell volume of 60%. A mass lesion was suspected, and no, Arun, it is not that thing which you are told. Mass lesion was suspected and the biopsy was ordered, which revealed the finding as shown in the image. Which is the most likely primary of this patient metastatic manifestation? So this patient is having a multiple coin shadows in the chest. So whenever you see multiple lesions in your lung, liver, bone, brain, multiple lesions in lung, liver, bone, brain, think of metastasis as the first differential, multiple. Okay, primary usually single, metastasis usually multiple lesions. Another clue they have given is the packed cell volume is 60%. That means its hematocrit is high. Hematocrit is high, that means there is a tumor which is producing a hormone which increases the RBC production. So erythropoietin is produced higher here. So out of this thing, which one will produce erythropoietin as a hormone and thereby causing a paraneoplastic syndrome? And also, yes, very good. And also see this, the biopsy which is taken from the lung also is showing the same features like that of a primary. So the primary also and the metastasis also will be having the features with a clear cytoplasm. See this, the cytoplasm is very clear. The cytoplasm is very clear. So with this clear cell morphology and the erythropoietin producing as a paraneoplastic syndrome of this polycythemia, the diagnosis is kidney, that is the RCC, renal cell carcinoma. So clear cell renal cell carcinoma is the commonest variant of renal cell carcinoma. And also please remember, both RCC and hepatocellular carcinoma both will produce erythropoietin and will cause paraneoplastic syndrome as polycythemia. Okay, and the RCC has a high propensity for vascular invasion. It can invade renal vein, can invade the inferior vena cava, and can reach up to the right atrium. And renal cell carcinoma has a high propensity that is involving the metastasis to unusual sites, like small bones of the hands and feet, head and neck, skin over the face. So this unusual sites metastasis is common in the renal cell carcinoma. And another important MCQ, what is Stoffer syndrome? That is the non-metastatic liver dysfunction. Okay, non-metastatic liver dysfunction occurring in renal cell carcinoma is Stoffer syndrome. So these are some of the MCQs. Yes, a 3-year-old boy is, yes, very good, IL-6. A 3-year-old boy is brought to the physician by his parents after noticing a mass on his left testis. The testicular tumor was confirmed and with the investigation and orchiectomy was performed. The histopathological findings are shown in the image. Which of the following serum marker is most useful for monitoring the recurrence of the tumor in this patient? Yes, testicular tumor in a 3-year-old child. Okay, younger age group, infants, children. So please remember, and also here see what is the morphology here. This is a blood vessel. So this is the blood vessel and this is the RBCs inside the blood vessel, and the tumor cells are arranged around the blood vessel. The tumor cells arranged around the blood vessel. So these are nothing but, yes, very good. This is the Schiller dual body. What is the other name for Schiller dual bodies? It is glomeruloid bodies. So what is the other name for Schiller dual bodies? It is glomeruloid bodies. So the diagnosis here in this 3-year-old boy, the diagnosis is yolk sac tumor. Yolk sac tumor, and the tumor marker for yolk sac tumor is alpha fetoprotein. Okay, so please remember also teratoma in females ovary, it can be either benign or malignant, but teratoma in a post-pubertal male always malignant. Very important point. Teratoma occurring in a post-pubertal male always malignant. Very important point. Okay, please remember. Also remember, seminoma testis is the most common testicular tumor. Age group of seminoma 30 to 40 years. A 60-year-old male presenting with a testicular mass. First differential is you have to think of first testicular tumor you have to think of is lymphoma. Very good, very good. Lymphoma will be your first differential. Other important tumors, spermatocytic seminoma can also occur in this 60 to 70 age group, but lymphoma should be your first differential. Yes, image of a pap smear of a 35-year-old female is shown below. Identify the organism. So this is an organism in a pap smear. No, this is not Don Pilif. Is very good, Dr. Naveen. No. Trichomonas and all will be like a very pear-shaped agent. Trichomonas vaginalis will be a very pear-shaped agent. So if I give you a clue that she is a IUCD user, intrauterine contraceptive device user, copper T, and if you can see a fluffy cotton ball like appearance. So yes, fluffy cotton ball like appearance in a pap smear. Please think that this is a actinomycetes. This is actinomycetes, fluffy cotton ball appearance. And also shish kebab appearance in pap smear, like a kebab appearance. Which organism? Kebab appearance? That is candida. Please remember shish kebab appearance, candida. Very good. And a quick review about the cells which you can see in a pap smear. When you see this light pinkish cells with the light eosinophilic cytoplasm with a small nucleus, dot-like nucleus, these cells are the superficial squamous cells. Superficial squamous cells. These superficial squamous cells are nothing but actually they are estrogen predominant cell, and they will be commonly seen in the proliferative phase of the menstrual cycle. And when you see the nucleus is somewhat bigger and the cytoplasm is slightly folded, these are the intermediate squamous cells. Intermediate squamous cells. These intermediate squamous cells are progesterone predominant cells, and they are common. They are usually predominant during the secretory phase of the menstrual cycle. Intermediate cells. And also please remember the cells with oval cytoplasm, oval in shape and somewhat greenish in appearance, the cytoplasm greenish in appearance, and the cells which occur in clusters with a scanty cytoplasm. These cells are called as parabasal cells with greenish cytoplasm. These cells are called as parabasal cells, and this cluster is called as a basal cells. Both parabasal cells and basal cells you can see in case of atrophy of the uterus. Atrophy of the uterus. Also, please remember, while discussing about the pap smear, you also should remember LSIL and HSIL. LSIL means low-grade squamous intraepithelial lesion, which corresponds to CAN1 in biopsy. LSIL in PAP and CAN1 in biopsy. HSIL correspond, that is the high-grade squamous intraepithelial lesion, will correspond to CAN2 and CAN3. Very important point. Okay. Is a 55-year-old woman presented with a 3-month history of postmenopausal bleeding. Pap smear results was normal. Endometrial curettage revealed endometrial hyperplasia without atypia, and CT abdomen revealed a 7-centimeter mass replacing the entire right ovary. And bilateral salpingo-oophorectomy was done, and histopathological examination of the ovarian mass shown in the image. Which of the following is most likely diagnosis? So she's a female in the perimenopausal age group, and she's having a postmenopausal bleeding. Pap smear is normal. Okay, pap smear is normal, but there is a history of endometrial hyperplasia. Endometrial hyperplasia. So endometrial hyperplasia, and also there is a mass in the right ovary. So endometrial hyperplasia plus mass in the right ovary, you have to think of a ovarian tumor with a hormone producing nature. Hormone producing nature. So you are seeing the histopathological image, and here you are seeing the tumor cells arranged around a concentric manner, or a concentric ring-like manner. So like a rosette manner. So the tumor cells are arranged forming a lumen or rosette-like manner. So these bodies are called as Call-Exner bodies. These bodies are Call-Exner bodies. Other important finding which you can note here is most of the tumor cells will be having nuclear grooving. That is, the nucleus will be having some grooves like this thing. So this type of nucleus is called as nuclear grooving or coffee bean nuclei. Coffee bean nuclei. So coffee bean nuclei, you will be having a 2 differential ovarian tumors in your mind. That is, one is granulosa cell tumor, ovarian tumors, Arun, I am asking, granulosa cell tumor and Brenner tumor. Yeah, I agree. Langerhans cell histiocytosis, papillary carcinoma, thyroid will also having nuclear grooving. But ovarian tumor with nuclear grooving, you have to think of granulosa cell tumor and a Brenner tumor. But here, it is a hormone producing tumor. That is, it is producing estrogen. So with this estrogen hormone producing tumor and its manifestation, we will making it, and a Call-Exner bodies, we are making a diagnosis of granulosa cell tumor. Granulosa cell tumor. Okay. So please remember granulosa cell tumor. Very important. And this actually in a perimenopausal age group, it presents as a endometrial hyperplasia. In a child, juvenile granulosa cell tumor, the manifestation is precocious puberty because excess estrogen. Some 8-year-old child, precocious puberty. The juvenile granulosa cell tumor. Okay, ovarian mass. Think that clinical history in your mind. Then a 65-year-old man presented with bow legs and leg pain. So there is a bone deformity is there for a period of 5 years. He also complains of progressive hearing loss. Hearing loss also there for the last 3 years. And a bone biopsy shows a mosaic pattern. Very important keyword. With prominent cement lines and increased osteoblastic and osteoclastic activity. The patient is at a risk of developing which of the following diseases? Risk of developing. Yes, the diagnosis of the disease is correct, Kavi, but risk of developing. Yes, the risk of developing, they will be, see, this is the characteristic, that mosaic pattern. And with the prominent cement lines, you can see these are all the prominent cement lines. And these are all the jigsaw puzzle pattern or mosaic-like pattern. And with this bony deformities and also the hearing loss, you will make a diagnosis of Paget's disease of bone. Okay, Paget's disease of bone. So Paget's disease of bone, actually one of the commonest cause for secondary osteosarcoma. These patients have been having a second risk of developing secondary osteogenic sarcoma. So Paget's disease of bone, other name for Paget's disease of bone, osteitis deformans. Okay, please remember osteitis deformans, and high output cardiac failure can be there in this patient. Okay, because of the arteriovenous malformation, skin warmthness will be there, and cranial nerve compression will be there, leonine fascias will be there, pathological fractures will be there. Very good. Cranial nerve compression, pathologic change in the hat size. So these are all the very important areas you have to remember in this Paget's disease of bone. Okay. Yes, very good. And the final question for today's discussion is, pheochromocytoma has been associated with the rule of 10%. The following statements are true about pheochromocytoma, except, please remember, pheochromocytoma is called as a tumor of 10%. So previously, actually, everything, many 10 were there. 10% bilateral, extraordinal, 10% occurs in children, 10% turns into malignant, all this thing. Previous edition of Robbins also, they have told 10% are hereditary. But in the recent edition, the update is 25% of the pheochromocytoma are inherited. It is not 10%. This is the recent update in the Robbins. 25% of the pheochromocytoma are inherited. Okay. And regarding the histology of pheochromocytoma, what is this pattern of arrangement? Yes, this is the characteristic, that is the nesting pattern. This pattern is called as the Zell-Ballen pattern. This pattern is called as the Zell-Ballen pattern. And what are the tumor cells? Here also the tumor cells will be having this typical salt and pepper chromatin. And here the tumor cells will be sustentacular cells will come on. These cells will be positive for synaptophysin and chromogranin. Okay, these tumor cells are positive for synaptophysin and chromogranin. And the tumor cells are surrounded by a fibrous septate, in which you will be having the sustentacular cells. Okay, sustentacular cells. And what is special about these sustentacular cells? Important MCQ, these are positive for S100. These are positive for sustentacular cells or positive for S100. So pheochromocytoma, Zell-Ballen pattern, synaptophysin, chromogranin positive, salt and pepper chromatin, sustentacular cells are positive for S100. So these are all some of the high yield topics for our pathology in CAT can be asked INI-CET. So overall in pathology, what areas I want you to concentrate is mainly in the genetics. Okay, genetics, a lot of the things actually can be integrated with any subject. So please remember, if you go through the genetics topic in and out, definitely you can score a high edge. And also the neoplasia and first chapter, cell injury and adaptation. And hematology, please, lymphomas, multiple myeloma, and always there is a question on the nutritional anemias, either iron deficiency anemia or megaloblastic anemia. Though they are looking like a simpler topic, every NEET exam or every INI-CET exams, there is a question on this iron deficiency anemia and megaloblastic anemia. And also there will be always a question in this hemolytic anemia, sickle cell or this thalassemia, one question will be definitely asked. Okay, and also multiple myeloma. And in systemic pathology, go through this vasculitis. Always there will be some 2 to 3 questions in relation to the vasculitis and ANCA related. And glomerulonephritis, kidney, glomerulonephritis. Many times the questions have been framed. And ovarian tumors, carcinoma cervix, many areas this thing can be focused. And endocrinology. And also about the CNS tumors and prion diseases. So these are Alzheimer's disease, neurodegenerative diseases, CSF findings in meningitis. So these are all the areas of somewhat important we have to concentrate in for your pathology, not only for INI-CET but also for your NEET exams. So dear students, wish you all the best for your exams, and thank you very much for a very interactive session. Thank you all very much. I enjoyed the session. Thank you very much.